emergency preparedness, and infection control. He also bears responsibility for enforcing the state's sanitary code. His previous state roles have included Assistant State Health Officer, Interim Assistant Secretary, and Regional Medical Director. Prior to joining the Louisiana Department of Health, Dr. Kanter served as Director of Health for the City of New Orleans and led the city's comprehensive opioid mitigation strategy. Dr. Kanter is a practicing and board-certified emergency medicine physician. He is the prior medical director of the healthcare for the Homeless Clinic and clinical assistant professor of medicine at both LSU Health Sciences Center and Tulane School of Medicine. Dr. Kanter's primary interests are expanding access to patient-centered care, promoting health equity, and creating efficiencies in systems of health while protecting vulnerable populations. Please welcome Dr. Joseph Kanter to the Press Club of Baton Rouge.
Dahlia, thank you so much. It really is a pleasure to be here with you. So thank you for inviting me to join you for lunch today. Let me thank the Press Club sincerely. Let me thank my wonderful team at the Department of Health, particularly Kevin Litton and Bob Johannesson, who helped organize and helped keep us straight. I also want to thank my wife, even though she's not here. You know, life's a little bit calmer now than it has been for us the past few years. We have two very small children, ages 2 and 4 right now, and my wife really carried the lion's share of responsibility during the times when things were really crazy. So I'm so very indebted for her. I wanted to thank her publicly. If you cover anything from today's event, please lead with that. So, but it is really nice to be here with you. You know, it's a much happier time and much calmer time than the last time I had the pleasure of talking with many people in this room, actually. We're very thankful for that. The topic of the bulk of what I'd like to talk about today is routine vaccinations. Not talking about the COVID vaccine. I'm talking about routine childhood vaccinations. And it's become a real concern for me, my colleagues in the state, and my colleagues around the country. So I wanted to spend a few minutes to explain to you what we're seeing on our end and why this is an issue of concern for us right now. I'll give you some context here. Of all the health challenges that we have in this state, routine childhood vaccinations has rarely ever been one. Traditionally, we have well exceeded national average for routine childhood vaccinations, and we've exceeded national average and also had the broadest vaccine exemption laws in the country. To exempt your child from school vaccine requirements requires no physician note, no notary signature, just a simple indication of that from the parent. That's the broadest allowance in the country, and with those allowances, which I support, we have still exceeded and excelled in childhood vaccination rates. That remains the case, that we still exceed national benchmarks on this, but those numbers have been slipping for the past 2 or 3 years right now. Not dramatically when you look at the raw data, but as I'll talk about in a little bit, small slippages in these coverage rates can mask larger problems within the community. And sometimes, particularly as we've seen in other parts of the country, it might be too late before action is really taken to address that. And that's the point of standing up today and talking about this. For the past 10 years running, we've well exceeded national benchmarks on childhood vaccinations, but they are slipping. So last year in Louisiana on record, our vaccination coverage standard benchmarks for kindergarten-aged kids was 94%. That was down 1 percentage point from the year prior, which was down 1 percentage point from the year prior to that. And for 5 years, between 2012 and 2017, we were at 97%, 3 percentage points higher than where we are now. Again, 3 percentage points doesn't sound like a lot, but I'll tell you, when you're talking about vaccines for measles, vaccines for polio, et cetera, it really is a lot, particularly when you're right around the threshold that we are. The U.S. average has also fallen during that time, and if you look at the top graph on those handouts, it makes it pretty clear. There are some good reasons for this nationally. The first one is the pandemic. The pandemic caused widespread disruptions in people's lives, in healthcare coverage, in the public health system, and we're still rebuilding and restarting from that. So a lot of families went without routine care for some period of time. School was interrupted. All of those factors contributed. But that's not the only reason. That's not the only reason. I'll tell you that the anti-vax movement in this country is better organized now, better funded now, more effective now than they have been in years past. And that's a trend that's also concerning here. Consequences, when we see these rates slip, are often insidious, but they can be quite severe. Let me give you a couple examples from across the country that I think should serve as warnings for us. We'll talk about measles first. So measles, you typically need estimated about 95% coverage in a community to maintain herd immunity. And what herd immunity does is it assures you that a small introduction of virus, a case here or a case there, will not snowball into an outbreak. That's essentially what herd immunity provides for you. And it takes into account that not 100% of the community can and will get vaccinated. So some people can't get vaccinated because they have an allergy to that particular vaccine. Some people are too young. Measles, for example, we don't typically give the first shot until 12 months. So infants are not protected, obviously. Some people might get the vaccine, but for all practical purposes, not confer protection from it. People who are immunosuppressed, who are cancer patients undergoing chemotherapy, or have innate immunosuppressive conditions, they won't bolster the same immune response to getting the vaccine, so the shot is less effective in them. Those people all rely on the protection of the community to ensure that, again, a case here or a case there doesn't become a larger outbreak. We're teetering right now, right at that threshold, right around that 95% threshold that confers herd immunity. That's really the bulk of the concern right here. Let's talk about a couple of examples across the country. Last year, Columbus, Ohio, a community that didn't have terrible vaccination rates by and large, but had large pockets within the community, family circles, small.
Can you pull that mic more and speak
Yes.
into it, because it's hard to hear you in the back.
Thank you for the heads up.
All right.
Yeah, is that better? Okay, appreciate that. Columbus, Ohio is a community where you saw pockets within the community with far lower vaccination coverage rates than the overall community rate would suggest. What began last year with 4 cases of measles in young, unvaccinated children in daycare, a daycare facility in Columbus, within 1 week's time, spread to 15 kids across 5 different daycare centers, and shortly thereafter spread to 85 kids, 85 people. 80 of those 85 were less than 5 years old. 25 of them were less than 1 year old. 36 of them were hospitalized. Thankfully, there were no deaths. And this is Columbus, Ohio, not 30 years ago, last year, in a community where the overall rate wasn't overly that alarming. Measles is about the most transmissible virus that we deal with. It has an R naught of 12 to 18 or so. R naught is something we haven't talked about since the first few months of COVID. R naught is how many people an infected person will then infect in an unprotected community. and are not of it. 12 to 18 means if I have measles and no one here has protection or is unvaccinated or never had measles as a kid, then I'm going to, on average, infect nearly everyone in this room, maybe half, minimum. It's a very, very transmissible disease. In a high-income developed nation like the U.S., about 1 in 5 kids who get measles will be hospitalized, and about 2 in 1,000 will die. So this outbreak in Columbus, Ohio, if it had gone on longer, there would have been deaths. There's absolutely no question about that. It took a lot of effort to bring that outbreak under control. It wasn't brought under control until February of this month. I'll tell you, the last time we had a measles case in this state was, we had 2 cases in 2018. Both of them were individuals who were unvaccinated. One was an adult who was unvaccinated. He was a traveler. He actually flew in to the state to attend WrestleMania in New Orleans at the Dome, and carried measles with him. The second case we had in 2018 was a 4-year-old child who was unvaccinated. Importantly, neither of those 2 cases spread at all, despite one of them being in the Superdome. Neither of them spread. And that's because traditionally we have done very well with routine vaccinations. It hasn't been a real problem compared to other states. That's the type of thing I'm worried that we might be at risk of losing. We'll talk about polio for a second also. Still dealing with a polio outbreak in New York State right now. I'll tell you, polio is often a silently spread disease. A lot of people don't realize this or forgot it because we haven't had to think about polio in a long time. But the overwhelming majority, 75% of people that have polio are asymptomatic. No symptoms at all, but can easily pass the disease to other people. About 1 in 4 people that get polio will have a mild illness that looks like the flu. Somewhere between 1 and 5% of those people that get symptoms will get meningitis, which can be very severe and can be fatal. Less than 0.5% of people that get polio will get paralysis, the real feared, storied complication of polio. People forget that. Less than 0.5% of people that get polio will actually get paralysis. But when you add that up in a population, it's compounding, and it's a terrible disease. The height of the polio epidemic in this country, the 1940s, 35,000 to 40,000 cases of paralysis a year. Those are the things that can happen if protections are allowed to wane. So last year there was 1 case diagnosed of paralysis in Rockland County, New York, that turned out to be polio. When you have 1 case of paralytic polio that you diagnose, it means you have thousands of asymptomatic or mildly symptomatic polio that you've not diagnosed. Of course you wouldn't diagnose this, because why would you be testing it for routine flu-like people in the U.S.? That's what happened in New York. This 1 case of paralytic polio was the canary in the coal mine. They went back and did intensive screening, wastewater surveillance, which is now much more common since the work put into it during the pandemic. There's now over 70 sewer samples within New York State that are positive for polio, spanning 6 counties, including New York City, including Long Island. These cases are genetically linked to cases in London and Jerusalem. Again, it's a global planet. People travel. That's what we see now. And there's a very intensive booster campaign going on right now in New York State, not talking, New York State, to bring polio under control. Again, it's a hard disease to bring under control because so many people, the vast majority of people that get polio, you would have no idea because they're silently shedding it to others without any symptoms. There was a large outbreak in the early 90s in the Netherlands. Again, a country which on the whole had decent vaccine rates, but amongst certain communities, certain pockets, had very low vaccine rates that ended up with 60 cases, 59 or 60 cases of paralysis, 2 deaths, all of which were unvaccinated. And there's a very expensive mitigation campaign happened on the back end to bring that outbreak under control. So we know that these type of outbreaks, if you let your vaccine rate slip even a little bit, these can be very challenging to deal with on the back end, very expensive to deal with on the back end as well, and you have real lives at the other end of it. So what is there to do? I think it's easy to take for granted the protection and the benefits that we've been afforded in this country, and particularly in this state, with the success that we've had with vaccines. I try to teach our medical students and residents this. I still practice emergency medicine in New Orleans, and this is first week of July. It's famously a dangerous time to be a patient in the hospital because we have a new crop of residents who started this week. But one of the things that we teach them in the ER, and this speaks to prevention, is the honest truth of medicine is that you've got some patients that are going to do fine no matter what you do. Honest truth. You also have some set of patients who are going to do poorly in their disease process no matter what you do. Pancreatic cancer, I mean, there are many examples where we don't have good therapies. You've got this slice of patients in the middle. This is what we teach our students, that you can really make a difference on. And it's not that you ignore the other patients, you certainly don't, but you really laser focus on the patients that you can really make a meaningful impact in their disease process. That's, to me, the meaning of preventable illness. When you have preventable illnesses like measles and polio that you, society, medicine, public health, can make a difference on, you do not let that slip through your fingers. August is going to be National Immunization Awareness Month. So my first ask to you and to the community is that we use this month as an opportunity to remind ourselves, remind our friends, remind the public at large of the value of routine vaccination. Again, I think a lot of us, this has been so successful, particularly in Louisiana, that we take it for granted now. A victim of our own success in a way. Let's use August, the National Immunization Awareness Month, as an opportunity to reflect and remind people of the protection that we have. Let's also use it as an opportunity to remind families to get their school children up to date before next school year starts. It's a good reminder. I'm doing that for my kids, my 2 young kids. That's a good message to spread across. We have very broad vaccine coverage in insurance policies in this country right now. There should be minimal, if any, out-of-pocket expense for routine vaccinations for kids. Cost and access should not be a barrier. All routine vaccinations can be given in a wide variety of settings, including the parish health units throughout the state. An excellent resource to send people to would be immunizations.la.gov. That's the site that we maintain. It links out to other resources as well. And always, always, the best advice for any family that has questions of what's right for them is to advise them to talk to their pediatrician. It's always special circumstances. That's always, always the best advice. And I'll tell you, with the expected political discourse this coming election cycle on vaccines, certainly seeing that now, I think this will need to be an evergreen message that we send out. Protection matters here. Being proactive matters. Staying ahead of the curve on vaccines pays dividends down the road, whether people realize it or not. That's the bulk of the message I wanted to convey on vaccines. I also want, just for a couple of minutes, to take the opportunity to reflect on the COVID-19 pandemic. It's been 3 years plus of full pandemic response. I'm very happy that that is over. I know you are too. I'll tell you, I brought a little bit of show and tell for you. Keep this on my desk to remind me of how crazy things were in the early part of the pandemic. In the first couple months, back in March and April of 2020, when we were leading the country in cases, first very large surge in a giant metropolitan area. We had the fastest growing outbreak of anywhere in the world to date for 2 weeks in the middle of March, faster than South Korea and Italy, even Wuhan, China itself at that point. It's easy to forget how nutty things were. One of the supplies that was going short across the country were swabs to perform the COVID tests early on. Couldn't get them. They weren't there. And this is when a lot of supplies were going short. Remember, we needed ventilators. And folks might recall that we actually were, the state was bidding on ventilators. We were bidding against other states. We were even bidding against the federal government on ventilators. It was a crazy time. The federal administration at the time, to help us out, sent us a crate of these. It's Kroger brand swabs. And this wasn't when we were doing the easy nasal swabs. We were doing the deep nasopharyngeal swabs. So, of course, we didn't use these. You can't use, this at least has the wrapper on it, but we had boxes without a wrapper and with scribbled writing on it. This is what people thought that we should be using. So I keep this on my desk to remind me of really how far we've come in this thing. That said, you know, the scars are deep. There's been 19,000 dead in Louisiana from COVID-19. We've had 7 surges right now. We're actually right now in the longest lull. The past 4.5 months we've been real flat, and that's the longest period of quiet that we've had throughout the pandemic. We're still processing and still learning lessons from this pandemic, and we will be unpacking it for quite some time to come. There's no question about that. That said, I think it's important to reflect on things that we did particularly well in Louisiana, because those are good lessons for us to take forward. I wanted to highlight a couple of those right now. We brought our school children back into the classroom earlier than most states did, and we did that safely. We did that in partnership with the Department of Education and with school districts. We did it early and we did it safely. We had a clear articulation of the equity challenges that COVID-19 brought, and we had good strategies to address that. I'll give you a couple examples of that. In the early months, we had some of the highest quality data on testing, on who was testing positive for COVID. There was a big problem nationwide in getting accurate demographic info attached to COVID-19 tests. We presumed there were inequities but didn't have great data to actually show it. We were quite innovative in Louisiana, and what we actually did was match our testing logs with other state databases that had good demographic info. The Office of Motor Vehicles, for example, had excellent data. This was, you know, when it's not being hacked, but had excellent and complete demographic data. We brought our demographic completeness up to 95% at a time when the national average was 55%. So we recognized the equity challenge. That once we had that data, it clearly showed that there were stark inequities in who was getting COVID and who was being hospitalized with COVID. We were able to identify that well before other states were. It led us to form the first COVID-19 Health Equity Task Force in the country. This was an initiative of the governors. And through that work, when the vaccine came out, and we, in the first couple months of rollout, had the same inequity challenges that nearly every state did, we devoted considerable resources and attention to that, and we were one of the very first states to achieve racial and ethnic parity in COVID vaccines. 3 months after that, in the fall of 21, we were one of the very first states to achieve mortality parity in COVID-19. And it remains the case right now that the mortality rates in COVID-19 are no different between black and white residents of Louisiana. We're very proud of the work that was done to do that. I think we led the country in that. I think we did a good job following data in Louisiana and making the best decisions with that data for Louisiana. You know, sometimes that differed from what the national recommendations were on both ends of the spectrum. For example, we brought kids back to school well before the CDC advised states to, because we believed we could do so safely based on the data we were showing. On the other end of that, when the Delta variant became prominent, we saw in our data that prior vaccine, because of the mutations, was not providing as much protection against transmission as it had been in prior variants. And we changed our guidance here well ahead of national guidance changing. So we followed our data, we did so timely. I think that was a high point of our response. I also think that the state set very clear, consistent, and logical benchmarks of how and where it would exercise its rare but necessary emergency powers. I mean, the governor, almost from day one of the pandemic, articulated that the ultimate red line in the state would be hospital capacity, that we would not allow our hospitals to be overrun and threaten the care for anyone in the state. And that's what drove the necessary rare mitigation measures. Other states came around to that as a benchmark, but it took some time. We articulated that pretty clearly from day one, and in retrospect, I think that was the right thing to do. I also think, we learned lessons well and actually have been able to apply those. Last year, when we started our monkeypox, now known as Mpox, outbreak, we had particularly liability here because our outbreak started about 6 weeks or so prior to the Southern Decadence Festival in New Orleans on Labor Day weekend, which was a huge liability. I think we were proactive in applying the lessons we learned in COVID to that response, and we were very proactive. We were aggressive at lobbying our federal partners for the resources we thought we needed. We obtained those resources. We were very aggressive at proactive vaccine campaigns, particularly around the New Orleans area, and travelers coming in for that event. And we averted a much larger crisis. We thought we were real at risk, particularly because of that conference and the amount of travel coming in. And we did not have any significant increase coming out of Southern Decadence last year. And I really think it's because we were able to apply some of those lessons about being proactive and how to work well with partners, federal partners, that we learned from the pandemic. So I have a couple more minutes. So the last thing I want to do before I take a pause and take questions is just mention mosquito-borne illnesses, because we're in mosquito season right now. And there's two different pieces of news that came out in the past couple of weeks. First is that we unfortunately now have our first 2 cases of West Nile virus neuroinvasive disease in the state. So West Nile virus, most people don't get symptomatic with it, but a small percentage will get West neuroinvasive disease, which can be fatal, can have severe complications. That's the real feared complication of West Nile virus. We announced our first 2 cases of that late last week. One's in Cato Parish, one's in East Baton Rouge parishes. But we're picking up West Nile virus in mosquito pools across 13 or 14 parishes right now. So it's out there in the state. It likely will get worse as the summer goes on. We had relative drought the past week and a half. That's going to change. That's going to bring more opportunities for mosquitoes to breed. So that should be on folks' radar. And the other issue is malaria. For the first time in 20 years, we have domestically transmitted cases of malaria in the country. One in Cameron County, Texas, which is Brownsville border town on the southeastern border, and now 6 cases in Sarasota County, Florida. 4 cases initially, and then 2 more were announced late Friday evening. Again, first time we've had domestic transmission of malaria in the country. We don't have any identified cases in Louisiana, but the mosquito that transmits malaria, the Anopheles mosquito, we have plenty of. So we certainly have the capacity for transmission. So all that said, there's a lot of reason to be mosquito conscious going forward this summer. And for folks at home, that really means taking care of any standing water around the house. These mosquitoes are container breeders. They can breed in a bottle cap that's overturned and has some water in it. So, what I do in my home is every 2 days I go around and just overturn any standing water. That can go a long way to preventing mosquitoes, basically starving them of potential breeding grounds. Mosquito repellent is very helpful, and when mosquitoes are out biting, folks should either use repellent or long sleeves, or both. And I think that's going to be something that we're going to have to deal with really over the next few months in the summer. So with that, I'm going to stop my prepared remarks again. I'm very honored to have the privilege of being here with you, and happy to be here in much happier times, the times before. So I will pause there, and I'm more than happy to take any questions there might be. Yeah. Yes, sir.
Doctor, is there any specific reason that you can point to why you think we're seeing a downward trend with these child immunizations, and is there anything you suggest be done to help kind of reverse that trend?
Yeah, again, I think like a lot of things, it's multifactorial. The pandemic and the disruptions that the pandemic brought with it is a big part. There's no question about that. Again, there were months where families did not get routine care. There were months where families were out of school. That's another vaccine access point. There were many months when the attention of the healthcare system was elsewhere. This is a national issue. So part of it is that. But the other part of it is, these anti-vax untruths are just out there in a way that's more prominent than it has been in years past. And there's a real movement behind that now, a real organized and funded movement that hasn't been as organized or funded in years past. And I think a lot of families fall victim to that or harbor doubts because of that. So I think it takes a lot of work to counter that. A lot of work happens in the doctor's office, but a lot of things can happen outside. So I think taking the time to remind families of the value and virtue of vaccinations, of what can happen when we forego them, of where we've come with vaccines in this country, I think that can go a long way. Yeah.
Just a quick follow-up.
Yeah.
Lawmakers this previous session cut $100 million from LDH's budget. Governor line item vetoed some things to try and put that money back there, but since then we've seen a lot of calls from lawmakers to come back to the Capitol and reverse that. In your opinion, if they were to be successful in that overturning, how would that affect you guys and your mission to counteract some of these trends?
I was asked to repeat the question. The question was about the $100 million cut to LDH's budget and the potential of that being overridden in the session. I would honestly be shocked if in an override session that particular issue was overridden. The challenge here is that it isn't just a $100 million cut, even though that would be bad. But the bulk of our department's budget is federal funds that we use state dollars to match and bring down. So a $100 million cut is actually somewhere between a $700, $800, or even $900 million cut, because we lose out the federal matching funds. And there are some things that we couldn't whittle down that are protected or mandated services. So that leaves other things that you only have so many choices. And so the challenge here is we're talking about real healthcare services to real families, families with individuals with disabilities that rely on services, mental health, which we're struggling with. Those would be drastic cuts. It was pretty evident that the majority of lawmakers didn't even know that cut happened. This was a quote unquote fiscal session, but they didn't seem to get down to brass tacks until the last 25 minutes of it. So I'll be shocked if that was overridden. I think most people understand that those services are important, that the compounding loss when you factor in the federal match would be devastating, particularly in a year where we have a budget surplus. So I'll be shocked if that happens. Yes, sir.
Your view of COVID is different from this official statement from a senior state official. From the very beginning of the COVID pandemic, the vast majority of leaders at federal, state, and local levels engaged in completely irrational decision-making while claiming complete autocratic power to justify those bad decisions. That was testimony to Congress, I think, last week or the week before. Is there a debate over public health that is damaging going forward as this retrospective view of COVID is put out there?
Who was that quote from?
Liz Burrow, testimony to the House Committee.
The question is about the wisdom of public health in general, and I think the politicized nature of it. And listen, this pandemic was a true 100-year event. There has been absolutely no precedent of it going back until the influenza outbreak of 1918. and those were very different times, obviously. And again, just to remind folks of how dire this was. I mean, there were days in late March, early April 2020 when we were counting the remaining ventilators in this state on two hands. And again, that's not just for people that have COVID. That's for people that have severe critical illness of any type. So it was a path that we had not been down before for all practical purposes. And I think, you know, as I have had the opportunity to reflect, you know, decisions were not easy, but every decision that at least I was a part of, the driving motivation was the preservation of human life, because that's what you can't get back. So I think it's easy to go in hindsight and get more granular on what went right, what didn't. I think that's important to do, and there's lots of time to do that. That work has started. But let's not forget that at the end of the day, our job was to preserve, maintain human life in the state. Yes, sir.
On your first page, I'm looking at where you have the comparison with the United States and Louisiana versus the United States comparison between those states. I wonder, is there any comparison with Louisiana, say, and other southern states to see how we have them, and whether Medicaid expansion might have something to do with it if there is.
Yeah, great question. The question related to our comparison of vaccination rates to southern states and then what impact Medicaid expansion might have on that. Again, we've typically exceeded most of our neighboring states, but many southern states have done well in this as well. You know, traditionally, we've not had the big anti-vax challenges that other states have had, and those have, you know, been advantageous to our vaccination rates. Medicaid expansion, I think, was highly important. Again, you know, there's now, you know, somewhere between 500 and 750,000 people that have Medicaid coverage because of expansion, and with that comes access to care and the assurance that they're not going to be, you know, liable for large expenses to obtain, first and foremost, routine and preventative care. Even though there are still access points to vaccines that go beyond that, I think when people don't have coverage, everything feels like a wall. It can be very, very imposing. So it sends the message that your health is important to us as a state, that we value your health, we want you and your family to be protected, and the door to health care is open. So I think that's important. And I do think that as we look to rebuild our vaccination rates or stop any further slippage, you know, relying on the coverage that Medicaid expansion provides, and certainly the strength of the healthcare system, whose finances have relied on that as well, are important. Yes, ma'am.
Are you planning a major campaign to get people vaccinated? What are you doing about this problem?
We are, again, we're going to look to the month of August, the National Immunization Awareness Month, to increase our opportunities to talk to the public, to engage with clinicians throughout the state, hoping to have some op-eds, hoping to put other issues out there. Actually, the man who's helping us mostly is at your table right now, sitting across from you. But we are looking to use the month of August to really remind people, one, of the value, what we take for granted for routine vaccinations, and then specifically to urge families to take that opportunity before the school year really starts in earnest to get their kids up to date on it. Yes, sir.
You said work's already being done to take a look back in hindsight of what the state did right and wrong during the pandemic. What were some of the things that you guys got wrong, in your opinion?
Sure. The question was, what things did we get wrong in the pandemic? I'll tell you one right off the bat is, you know, we, and I say we, I mean me, myself included, but the general public health community, at the very early days of the pandemic, envisioned an outbreak where it gets very bad, and then it slowly gets better and better and better and better, and then it's over. And if you remember back to the Reopening America guidelines that the Trump administration put out, phase 1, phase 2, phase 3, phase 4 of reopening, the Trump administration advised certain closure guidelines and then provided suggested benchmarks of when they thought states could roll back another one. You know, that envisioned a very linear pathway to exiting the pandemic. I think, and I certainly felt that too. What we didn't realize at the time was that this was going to come in waves. You know, we've had 7 waves in Louisiana, and there were times when mitigation measures had to be rolled backwards or forwards based on what that was happening. That wasn't well articulated or thought of. In hindsight, I'll tell you, that is what happened in the 1918 influenza pandemic. That was a pandemic that lasted a few years. It had multiple waves. In hindsight, the COVID pandemic has a lot of similarities to that one, but that wasn't where people's heads were at, you know, at the very beginning.
Any other questions?
Yes, sir.
You, on this information, is this mandated both for public and private and charter schools? And is that data included in here, or are you using the public school information to extrapolate to private and charter?
The data you're looking at is all schools, and there's more granular information available that we maintain on our website, and I believe, I'm fairly certain, although not 100%, that you can find online a breakdown between public and private school institutions to see the difference there. In individual school districts, yeah. So it'll show the breakdown between that. The school vaccine schedule is applicable to every school in the state, but again, we maintain the broadest exemption allowances in the country. So, you know, mandated isn't the word that I think would be used, because any family can avail themselves of an exemption for the vaccines, but that schedule is applicable to any school in the state. Yes, ma'am.
I wanted to ask about the opioid epidemic and how you see the status of that and making any inroads.
Yeah. Great question. The question is about the opioid epidemic. This is a major challenge in Louisiana and nationwide. So in the past 2 years, we more than doubled the number of opioid-involved overdose fatalities. We're at 1,300 and change right now. That's nearly double in the past 2 years. There's some suggestion, we haven't put out the last year full data yet. If you look at quarterly data, there is some suggestion that we're plateauing. But there's a lot of work that has to happen. You know, we were making good progress on the opioid challenges before fentanyl became such a ubiquitous substance. And what's happening now is nearly every opioid that's out there on the street, illicit drugs, contains some degree of fentanyl. That's relatively new. And the problem is people who use have no idea how much fentanyl is in there. It's so potent that just a little bit can have huge, huge impacts. So the risk of overdose is just so much higher. And you know, one of the realities of addiction is that relapse is an expected and anticipated part of the process. And for anyone that has family members or loved ones who've struggled with addiction, you know that relapse is part of the process. But when folks relapse with opioid addiction, after having not used for some period of time, they've lost some of their tolerance, and they're that much more vulnerable to overdose, and fentanyl really pushes it over. So with the fentanyl that's out there now, it's like if before an opioid user was walking a tightrope that was 10 feet off the ground, now it's 150 feet off the ground. You know, the consequences are just so much dire. On the other hand, we have better tools now. There are good evidence-based medicines to treat opioid addiction. Not every type of addiction has good medicines to treat it. For example, meth addiction, we don't have great medicines. But for opioid addiction, we have really good evidence-based medicines to treat it. So our challenge is in how to connect people to that. The biggest stumbling block is stigma. I'll tell you that. It's stigma. It's that we stigmatize addiction in a way that we don't stigmatize other medical conditions. It's a medical condition. It's a disease of the brain. But because we stigmatize it, because society looks down on people with addiction, or at least people with addiction feel the society is looking down on them, that makes it less likely for people to get treatment. So we've done a lot of investment in the state to expand what we call medication-assisted treatment. This is evidence-based medicines to treat opioid addiction. There's good access to it. Insurance is never a barrier. If people are unfunded, uninsured, they can still get access at many places throughout the state. I think the challenge is just supporting people and connecting them to that. So I'll give you a website. It's opioidhelpla.org. That's probably a good first step. But the biggest challenge now, we have access. We have good access. We need to help support people to take advantage of that. Yes, sir.
Well, we're in a political season, as you know, and I just want to ask this one question. If you had just one wish that would be granted, what would you wish the politicians that are running the statewide office or the Louisiana legislature would do or not to help you and your office do your job effectively?
In addition to the $100 million cut? Well, look, I mean, this is a state that has a lot of health challenges. And so I think it would be wise if anyone seeking office to take some time, talk to families in the state about what really challenges them and the health of their family, and then adjust their policy platform towards that.
Thank you, Dr. Kanter. Next week, Dennis Shields, president of Southern University, will be our speaker. Thank you, guys.